All right, so fluids. So talk about fluids and fluid balance, I's and O's, daily weights, insensible losses there. How much fluid should a patient get? Should they be getting fluid in the first place? Is too much fluid going to be a problem, right? And as we know, it probably is, right? So fluid is a disruption to normal physiology. It separates the distance between oxygen and the cells, right? Cells have oxygen has to leave the hemoglobin and it has to then attach to the, it has to travel through the spaces to get to the actual cells on the other side, right? So, if there's more fluid, there's less diffusion, there's increased diffusion distance, there's more fluid, more distance to travel, and just hypoxemia could be a result, not just the interstitial edema that might occur or the other processes that might get interrupted, or the pressures that might build up, okay? So talk a little about some fluids some more. All right, some isotonic fluids, such as normal saline and LR. All right, so we're gonna make sure we're making good choices as far as the fluid choices as well. We're gonna talk about a lot about metabolic acidosis and alkalosis, your HAGMAs and your NAGMAs. So we'll talk about those in detail, what all those mean, and then we'll talk about hypovolemia and hypervolemia at the end, as far as how much fluid should a patient be getting. Is NS at 75 or LR at 125 too much or too little for a patient? All right, so fluids. So packed RBCs. So back in the day, they're like, give everybody packed RBCs. That's what should they need, right? More RBCs means that they should have better oxygen carrying capacity. That's great. And as we're learning hematology, there's a lot of transfusion reactions that can occur. So it's not always great unless they are actually bleeding. So if they're actually bleeding, then they need PRBCs. Otherwise, it's not a great fluid to be giving. Okay. And what about Hetastarch? You may have seen Hetastarch in literature and textbooks and other areas, but this one is actually a poison. It's literally been told by the FDA, says it's not safe to give. Please don't give Hetastarch, right? It causes AKI, acute kidney injury, it increases mortality. Right? It has no medical legal evidence to give it, right? There's no like fifth line, like, oh my gosh, let's give it now. There's no other reason to give Hetastarch, all right? So if you ever see Hetastarch, that is always raise your hand. It's like, can we just give packed RBCs instead, right? But because packed RBCs, again, aren't the best choice, but, it's better than Hetastarch. And what about albumin? So albumin is it restores oncotic pressure. It puts proteins into the vascular space, and that's going to take all this water, right, from the interstitial fluid, all this water out here, and it's going to pump it into the vascular space, restore blood volume. Sounds great theoretically, right? Perfect. But then they found that there was no difference between albumin and normal saline, or albumin and regular crystalloids like LR or NS. So, so the hospital said, well, why are we spending $200 a bottle on albumin when we can spend $1.25 or 75 cents on normal saline or LR? So yeah, so there's no difference. It's okay, but it's not going to have, there's no evidence that it's better. So why use it, right? There's no like side effects as far as like transfusion reactions that occur from it though. But it is expensive, right? But who is albumin for? Who is it appropriate? That's someone that is cirrhotic. And we have 3 complications that could lead to need for albumin. So usually when you see albumin hanging, it's because, do they have a history of cirrhosis, right? Because that's what we're usually given for. They have spontaneous bacterial peritonitis. They have hepatorenal syndrome, or they have large volume paracentesis, an LVP, right? They had a 5 liters or more taken off of their body, and that 5 liters just going to fill up with fluid again if we don't put albumin into the vascular spaces. Otherwise, all the water is going to leave the vascular spaces if there's no albumin around, right? And that's going to make them what? Have what symptoms? Some hypotension, right? For sure, because they're going to lose all that volume that was in the vascular space is going to be lost because they just took out a whole bunch of fluid in the acidic area. All right. Another reason why you might see albumin given is they'll say, hey, let's give albumin, pull the fluid, and then let's give Lasix, and we're gonna 1-2 punch. We're gonna get all that fluid out. Makes perfect sense theoretically, but there's no evidence it works. So, but you might see it ordered, right? There's no evidence that that's actually beneficial, but it kind of makes sense, right? I'm going to pull fluid, and then I'm going to follow up with Lasix right afterwards, right? Get rid of that extra fluid that we just pulled in from the interstitial spaces, from the edematous areas. Okay. All right, and then we have NS versus LR. So we have a normal saline or LR are 2 options as crystalloids, and we have options, right? We have to decide, is it okay to give normal saline or is it okay to give LR? And there's another third fluid out there that's called isotonic crystalloids, or what is it called? Balanced crystalloids. Sorry, that's bicarb drip. All right, so we have bicarb drip is a variant. It's obviously alkaline because it has bicarb in it, and it's going to be for those patients who are hypovolemic and are acidotic. And do we have patients that meet that criteria? Like a sepsis patient, for instance, right, is really acidotic, lactic acid, and hypovolemic. Or they're not really technically hypovolemic. They're fluid. They have a decreased circulating blood volume, right? But we have these guys that are balanced. They have LR, Plasmalyte, and bicarb drip, right? Bicarb drip is great for those that are also acidotic, right? But we'll talk about LR versus Plasmalyte, I think, on the next slide, right? So those guys are very, very similar, and they are balanced, right? So do you believe that pH, hyperchloremia, and acidosis matter? Then you need to be using these ones. If you don't care about acute kidney injury, you don't care about inducing acidosis in your patient, then it's great. Go ahead and give normal saline. Give Hetastarch. Who cares, right? So the most dangerous thing we can say is that we've always done it that way. So that's what we should be doing, right? That's not an appropriate statement in any kind of anywhere really. It should be a tradition works as long as it's evidence based. Okay, so. Why use NS? Because you want to cause metabolic acidosis. That's great, right? If someone has profound metabolic alkalosis, right? They overdosed on their Tums. They got the baking soda in the fridge. Like, come to Papa, right? And they down that baking soda. Then that's going to be great. They're going to come in with very severe alkalosis, and we should give a fluid that's going to induce acidosis. Sometimes we overdo it and we give too many diuretics to patients, right? And they pee out a lot of fluid and potassium. And that, of course, will cause some alkalosis, but also all the volume will be less. And sometimes we overdo it. And then, yeah, normal saline would be great in those patients because we're going to restore the volume, and we're also going to induce metabolic acidosis because when they pee out too much volume, it causes what's called a contraction alkalosis. All right? So we'll talk about the causes of metabolic alkalosis coming up. All right, so if you want to cause an AKI, it's called a hyperchloremic metabolic acidosis. It constricts the renal vasculature, right? What's going into the glomerulus, right? So here's our glomerulus right here, getting volume, right? So volume should just go right there into our glomerulus. But what does hyperchloremia do? It just vasoconstricts this, so it literally decreases GFR dramatically, right? Decreases GFR. So that's going to reduce renal blood flow, inducing an acute kidney injury, right? When you want to exacerbate hyperkalemia due to acidosis, and yes, give an acidotic solution. That will then cause the acidosis to get worse, cause the hyperkalemia to get worse. So hyperkalemia is a contraindication to normal saline. All right, you want to increase mortality. So in critical care patients, right? They found that med-surg patients doesn't really matter. If they come to the ER and they get normal saline and they go to the med-surg floor, it doesn't really increase mortality or cause acute kidney injury. But if they get normal saline in the ER and then they come to the ICU, it does increase mortality, increase acute kidney injury, increase the need for dialysis. All right, that was called a Get Smart trial. All right, and they chose saline versus LR and said what happened, right? So they found out that saline was not great. Okay, so why use LR, right? So it's usually the reason, right? A reason why you might not use it is if there is severe acidosis. We got bicarb drip, which is a great alternative, right? It's not wrong to use LR, but bicarb drip would be better. Okay, so hypercalcemia is sometimes listed as a reason why you would not give LR because LR has calcium in it, right? So we don't want to raise the calcium. Is it going to raise calcium that much? No, but like a lot of resuscitation with LR, yes, could raise calcium just a little bit, right? So we have an alternative, and that alternative is Plasmalyte. So again, we'll differentiate Plasmalyte and lactated ringers. But Plasmalyte is like lactated ringers, except it doesn't have calcium in it, so it's a better alternative. All right, it's more expensive, but it's something we can use. Okay, LR is not compatible with some IV piggybacks like Ceftriaxone. All right, so what does Ceftriaxone say to lactated ringers? Don't like you. All right, I dislike you strongly. All right. So LR and Ceftriaxone are a big X. We can't give those together. So if you have primary fluids going, you're going to spike Ceftriaxone, which is an antibiotic we try on everybody, right? And obviously, it's unfortunate, it's not great. Okay, has it been done? Probably, but it's not an interaction that can happen. So Plasmalyte would be an alternative in that case, right? And then LR is compatible with blood, technically. Right, so they've in some trauma literature and recent findings, they found that not only NS is not the only fluid that's compatible with blood, LR is also, right? So they're saying, well, if you give LR and it has calcium in it, and the calcium can activate the coag cascade, you're going to clot the RBCs on the way in. But the RBCs have a preservative in it, EDTA or calcium citrate, right? So that means you can't give blood to someone who has hypercalcemia. What are you talking about? What's going on here? All right, so yeah, they found out that definitely in traumas where we give a lot of blood, then it's okay to give LR in those situations. It still needs to be like rubber stamped by many different organizations, but there's a lot of literature that supports it. Okay, just FYI. And then of course in trauma, do you want them to have acidosis, hyperchloremic metabolic acidosis? No, that's going to worsen the coag cascade in of itself, right? All right, and traumatic brain injury and increased ICP. It's entirely theoretical that that giving LR would cause a worsening situation because it's slightly hypotonic. It's like 273, right? Which is not crazy, right? They're saying, well, NS is 295 or what is it, NS? It's maybe barely isotonic. So it's like, oh, we have to give that for all of our neuro patients. Otherwise, if you give too much LR, it might make them hypotonic, and you might worsen their outcomes. And that's not been proven by any research. It's just theoretical. Okay, and then absolute liver failure. So people are saying, oh, liver failure, you can't give if someone has liver failure because what happens is the lactate is digested or not digested, but converted into bicarb, or a bicarb derivative or a bicarb-like substance, and therefore if I don't have a liver, the lactate is going to go up. But it's not lactate, it's not lactic acid, it's sodium lactate. So we'll point out the chemical situation on the next coming slides, right? But it's a negatively charged ion, and it's designed to bind all the positively charged hydrogen ions. So it doesn't make sense. And maybe if someone has like an AST, ALT of 0, like on a transplant floor, maybe you could, sodium lactate, when it builds up, that could then cause because it is a little bit oncotic, it could cause a little bit of cerebral edema, maybe, but it's actually known to be a fuel for the heart, brain, heart. It's actually beneficial for the brain, beneficial for the heart, all right? Sometimes people say, don't give LR, it's too expensive. It's like 25 cents more, right? And then they're saying, well, they have, if you dialysis from normal saline, it's a lot more pricier than a little bag of LR, okay? And then people say it causes hyperkalemia. That is not true. It will demonstrate the math, but it's a 4 MEQs in a liter, right? That liter is going to dilute out the serum before the 4 MEQs causes the potassium to go up, okay? All right, so those who use normal saline, they're about right here on the pathway to what we are growing to using fluids, right? The right fluids nowadays are ones that are, balanced crystalloids. All right, balanced crystalloids are where it's at. All right, so yeah, so LR versus Plasmalyte. So we'll talk about those on the next coming slides. So hyperchloremic metabolic acidosis. So just to clarify what's going on there, we talked about the vasoconstriction going into the kidneys, right? For the kidneys to get blood flow, right, to push blood down into this nephron right here, to go down this nephron, to get flow to the kidneys, to manipulate the ions and electrolytes and solutes and such, we have to get flow to our kidneys, right? If you don't get flow to your kidneys can die too. So we want to make sure we have a good, adequate flow, and that's what the renin, angiotensin, aldosterone system does, right? It squeezes down on this exiting arteriole, or the E for exit. It squeezes down on that. If it squeezes down on that, that's going to be great flow down this way, right? It's like beautiful, right? I did not mean for that to animate. It's just my markings go away for some reason, right? So yeah, so that's going to reroute blood flow down into the nephron, which is what we want, right? So when you give normal saline, though, that's going to cause this hyperkalemia, which is not great for for functions in general. But also the acidosis has caused widespread vasodilation. If we vasodilate widespread, that's going to not give great flow to the kidneys just from the arterial situation. It's also not going to give flow to the kidneys from a systemic point of view, right? We vasodilate everywhere. You're going to start losing blood volume or effective arterial blood volume to your kidneys. All right, so it causes an AKI through afferent vasoconstriction. So on the afferent or arriving arterial, that vasoconstricts, and therefore there's less flow to my kidneys, right? And then there's a lot of research nowadays with hyperchloremia, that it's actually has bad things that are resultant of hyperkalemia on the JG complex specifically, right? It inhibits this COX-2 enzyme, which makes prostaglandins. What do prostaglandins do? They vasodilate that afferent arterial. So if we get rid of that, we have vasoconstriction. So chloride is kind of doing both, right? As we mentioned, right? And this is the idea that hyperkalemia is going to also pull a whole bunch of fluid inside that nephron, and that's going to be like fluid overload of the nephron. The nephron's like, I can't move. I'm not, there's way too much fluid, and it can get ischemic from that. But also for this volume to go down into the I don't know why that keeps going away, but for volume to go into this nephron, right, it needs to, there's a pressure gradient there, right? So there's pressure going this way, and there's pressure going this way, right? So that's what establishes glomerular filtration, is just like with ICP and CPPs or MAP and coronary perfusion pressures, you have to be able to get fluid past that glomerulus. And if this nephron is all full of fluid, it's going to be pushing a lot of extra pressure into this glomerulus space, and therefore you're going to get less flow to the nephrons, and therefore you're going to get more ATN, more acute tubular necrosis to develop. Okay, so that's the idea. So you can see that with the creatinine goes up with saline, right? So the saline is going to go up with creatinine, and whereas we give balanced crystalloids, it kind of stays even. Okay, so that's the idea why we would want to use a balanced crystalloid versus normal saline. So balanced crystalloids such as Plasmalyte and LR. So we're going to talk about these guys, just what the difference is between the two. So in orange is our LR, right? So LR, we kind of know a little bit. LR is, it has calcium in it. So we compare LR over here. LR has a little bit of calcium in it, whereas Plasmalyte does not. And other benefits of LR is that it has this sodium lactate ion, right? So it's so sodium, LR Plasmalyte has these things. So sodium lactate. So what is sodium lactate? So sodium is positively charged, right? And the lactate that it's bound to is negatively charged, right? So this ion right here, I meant to change colors, and I did change colors, just did not take. So you can see it's negatively charged, right? So negatively charged are going to slurp up all the hydrogen ions, right? So hydrogen ions are going to be slurped up by sodium lactate, right? They're all going to be gone. That's the idea, right? And that gets converted, yes, in the liver, and your liver has to like literally be dead, or AST, ALT of 0 before you had a problem with LR. You might want to pump the brakes and say, is it okay we give this, or should we maybe give Plasmalyte instead, right? So hypertonic sodium lactate. So this sodium lactate is what establishes the osmolarity of the LR, and you can see the LR's osmolarity down here is about 274. Like, oh, it's hypotonic. You can't give it to traumatic brain injury patients. It's like, that's not going to make or break the difference, right? And usually TBI patients don't require a lot of fluids in the first place, right? Whereas normal saline is like 308. It's like, oh, that's perfect for my brain injury patient, right? So it's feared to worsen lactic acidosis. This is literally not possible, right? I still see this all the time. Like I just saw someone post a post on a forum saying, oh, I don't give lactated ringers because it increases acidosis. Like, okay, that's been well proven that it does not. It literally, I think it's like 1863 is when lactated ringers came out, right? So it's like almost like 150 years. I don't know why we still say it causes lactic acidosis, right? So when you think of lactate, yes, you do think of acid, but it's not lactic acid. Lactic acid is this guy right here, right? So it has an O negative over here, and the H is going to branch off, and yes, that will cause acidosis. But we're not giving lactic acid inside the serum or inside the solution. We're giving sodium lactate. So there's differences there. Okay, Plasmalyte is great because it lacks calcium. For those that are concerned with calcium, right? You can see down here, we said calcium was absent. Also, Plasmalyte has magnesium in it, which is cool, right? So someone has a mag that is borderline, it might help a little bit, but it's 1.5, so it's not going to, things work by diffusion, so it's not going to like incredibly raise someone's magnesium. It will just gently raise the magnesium and prevent hypomagnesemia. Okay, so Plasmalyte doesn't have sodium lactate. It has two other solutes in it that give it a osmolarity that is a little bit better. All right, so it might make the neurologist and neurosurgeon a little bit happier because it's 295. That's great. That's perfect. 285, 295. That's what I want, right? But because 285 being our normal serum osmolarity. But this sodium acetate, sodium gluconate, these are solutes that are meant to neutralize the serum and neutralize hydrogen ions, right? So sodium lactate will neutralize the hydrogen ions, so will sodium acetate, and so will sodium gluconate. They once thought it did. Then the research says, oh, actually it doesn't do anything. So it's not metabolized at all. It actually kind of it's osmotically active, so pull a little bit of fluid into the vascular space. But sodium acetate is converted to bicarb, and it will cause a little bit of vasodilation, but it's not significant. And you can see that, going back up to sodium lactate, it's actually fuel for the brain and the heart, right? So our heart and our brain love LR, right? That is what they like, and that sodium lactate, if it doesn't eat up all the hydrogen ions to neutralize the pH, it will be fuel for the brain and for the heart, all right? So severe hypercalcemia might be contraindication for LR, all right? And blood products, as we mentioned, sometimes they'll say, well, don't give it with blood products, but again, the trauma literature is leaning more towards giving LR because they know normal saline is really, really bad, so they're leaning a lot more towards LR now, okay? And then metformin, right? Metformin is going to stop the conversion of sodium lactate. So that's a reason to hold LR, and it might be kind of a similar thing with Plasmalyte, but it's not proven just yet. All right, effect on potassium. So both fluids are safe in hyperkalemia. It's been well demonstrated in all the literatures that it's perfectly fine to give it in hyperkalemia. All right, hypomagnesemia. All right, LR doesn't have magnesium, but Plasmalyte does, and it may gently raise the magnesium. Okay, calcium. So if you're hypercalcemic, then Plasmalyte would be a better option. Right, compatibility drugs. Right, there's doesn't have calcium with Plasmalyte, so it's compatible with which medication that LR is not compatible with? Ceftriaxone, right? So this one hates ceftriaxone, right? Ceftriaxone, it's like, no, I don't like you anymore. All right, so what anions, we said sodium lactate was actually a better ion, right? They had these other theoretical ones with Plasmalyte, but it's not as good, okay? Cost, it is more expensive for Plasmalyte, and evidence. So there's a lot of evidence that LR is better than NS. They haven't really compared LR versus Plasmalyte as much just yet.